glad to see all colleagues in these meetings. Today, the first live case is a bifurcation case. I'd like to invite our panelists first, Şükrü Ünal, Taner Şeker, Yakup Çetinkaya, Oğuzhan Varan, Yakup Alsancak, Samet Yılmaz. We will be hearing some particulars about the course of the case and their ideas in this meeting. For the connection, we're ready, I guess. Kürşat, good morning. Sinan, good morning. Welcome to the station. Thank you. Can you hear me? Yes. I'd like to welcome you all by heart from this beautiful city of Kayseri. Ergin University Lab is the place where we are realizing the surgery. We will try to contribute with our best. Today, the first case is a bifurcation case. We evaluated the case, we saw the images. So first, let me present the case and then we can receive the ideas. And then we will continue. We placed our 2 wires and we did an IVAS in the LAD part. We have angiographic images, but we stopped here. We can make a consensus and continue. 75 years old male, hypertension, coronary artery disease, bifurcation patient without hemodialysis. For 1 year, he has angina and shortness of breath. There is no pathology, only creatinine increase due to coronary bifurcation. In MPS, inferolateral wall and inferoseptal wall meet apical lines. Mild to moderate ischemia is seen, and the patient is admitted for the operation. Some critical stenosis exist in these patients. About the surgery, our plan is that when we first saw there are distal lesions, especially you can see the angiography. At the circumflex distal, there is a thin stenosis. In VCA, there is an interim lesion. Maybe LAD and RCA was planned for stent implantation, but today our target area is LAD diagonal bifurcation, and the lesion is 0.1, especially it's not a long one. We can see that it's around 50 to 60% stenosis. It's a short segment lesion, and diagonal is a developed one. The diameter seems to be 2.5 millimeters, and it was protection or operation. And after the separation of diagonal, the LAD lesion is a series one. There is not a series calcification, but there are calcific segments as well. And towards the distal of LAD, around 50 to 60% stenosis is caused by plaque. And in IVAS, we also saw the plaque in that region. We will continue with a provisional strategy, and we will protect the diagonal, and we will extend towards the distal for the stent. This is our stent implantation plan. But after seeing the IVAS images, we will also show you the other angiographic images. We are also wondering about the ideas of the panel members. And this is the cordial pose. And here you can see that at the LAD proximal there is a flag, but at the protrusion of the septal there is a larger segment. And in IVUS we measured it as 4.0, and with a 3.0 stent we will do an operation here to overcome the stenosis. And in the nitrate poses, after the bifurcation, the stenosis becomes more clear. Maybe a longer stent can be selected to cover that part as well. After the IVUS images, I will give the floor to you. Can you please show the latest IVUS from the distal to the upwards? Can you see the IVUS now? Only the LAD run from the distal to the proximal it was taken. Please come to the most distal side. Here you can see the diameter of LAD at the distal segment is around 2.75 millimeters. And here you can see those regions are stable but not causing a critical stenosis. From time to time, a serious calcification is not seen. At these points, the diameter is around 3.0. And here it's around 3.0 T. When diameter is around 3, the septal and diagonal parts are separated. Here, the diameter is 3 to 3.25. There's not a clear calcification. The diagonal orifice is seen clearly, but before the diagonal, the stenosis seems to be critical. It involves the around the iris catheter. The new one is not seen. At the proximal side, there is an enlargement. At these segments, the diameter is around 4 millimeters, but there's no clear calcification again. And here you can see the main coronary orifice. And here in these regions, we can start from the main coronary, and there is a black burden, not causing a serious calcification, but some stenosis occurs. And if we can protect the stent in the septal part and extend it to the distal, it will be good. But at the distal part, the stenosis, the diameter of the vein becomes smaller, and we are anxious about the oversizing of the stent. This is the first findings. We can discuss it together before continuing. Thank you very much, Kürşat. We will give the floor to the panel now. What are your opinions? Let's start with Şükrü. Provisional approach would be my approach. There are lesions at the diagonal part, but as far as we can see, the visual evaluation is more critical. Therefore, there is not a critical lesion at the distal. Therefore, provisional approach would be better. Thank you. My name is Taner. The lesion at the diagonal part seems to be longer than 10 millimeters. Therefore, there might be plaque. The lesion beneath seems to be critical. Wire protection will reduce the flow. I would start with a double stent, mini-clot or double clutch. And another recommendation is, especially at the NID part, the lesion may involve bridge component, not attaching there, only beneath the diagonal. After the critical lesion, I would terminate the stent, not intervene in the mid part. Okay. I totally agree with Ömer. The diagonal is quite good. Secondly, after the diagonal, the stenosis seems to be calcific. Therefore, first a double stent technique may be adopted. It will be better for this case, but provisional approach is also an option. Hosam? If we think of provisional option with a wire Bellonji, what about Bellonji application? Well, Kürşat, when I see the case, the risk factors and age are considered, I would prefer single stents. But what comes to my mind is that in scintigraphy, the ischemia is at the inferior wall. And if there is any complication after LAD, the hemodynamia of the patient will be disturbed. So I would also start with a provisional approach. But what about the complications after LAD? Okay, I would also protect the diagonal, therefore provisional approach would be good, but with iPad, diagonal flow would be protected. These are the opinions of the panel. Where I will give the floor to Ömer now. Well, first of all, I have a question. Today, can we also see the other images you took today? I showed them all. You can see on the screen. This is the AP caudal image for evaluating the LAD proximal segment. You can see the free area. This circumflex ostium seems to be ill also. Yes, there's also a stenosis, and we will evaluate it also. And in RCA, there is also a problem. But our target lesion is the bifurcation here. Is there any at the left cranial? When it overlaps with circumflex, it seems better. At the left cranial, the creatinine level is high, around 59. Therefore, we prefer to work in a smaller area. And this is the position we can work better. So the diagonal orifice is overlapping at the left cranial. It seems to be critical, however. When we look from this part, the lesion is not that problematic. In IVUS, at the diagonal ostium, there is a plaque burden. A provisional approach may be adapted, yes, but my insight is that when you start with provisional, the diagonal stent would be required. Maybe the result would be good. The friends who said start with double stent, yes, they may be right. This is a big diagonal, but considering the patient's age, I would also start with provisional in the first place. After the provisional, if such image would be achieved, yes, it's okay. Okay. Actually, after the provisional, if there is tibial flow at the ostial segment, if there is a serious stenosis, it may not cause much ischemia. We can complete with the bailout 10. And also we can use balloon gel to ensure a better branch clearance, but it wouldn't change any strategical thing. Maybe the stent strategy, provisional strategy are all right. And in our discussion, we will also see that as the patient has kernel insufficiency, in this patient group's double stent strategy may cause thrombosis, but because the creatinine levels are high, maybe dialysis may be required for the patient in the future. Therefore, using minimum stent and minimum complications are our targets. Therefore, without involving the distal segment, we can complete the session, and if required, we can use another stent. If from this part, if we take it from the other part, then a longer stent would be required. And that time during the potting at the expansion capacity, there might be a problem because I want a 3/0 stent. And at the bifurcation part, I would do the stent, and then if the distal lesion seems problematic to us, we can do an overlapping there with another stent. Then we continue. Yes, actually, I would cover the distal lesion, and when we look at the LAD with 3/0, LAD is not a small one. I think that area would tolerate 3/0, 38 or 33. That would be my starting point. I agree with you. Now let's inflate the balloon of 2.5. If I am all right with the sizing, I would use a 33 or 38, extend it to the distal and cover it. Our first orientation is also like that. What about the panel's opinions, long or short stents? Cover 2 lesions or just cover the bifurcation part and postpone the distal? I would leave the lesion at the LAD mid because we cannot evaluate the proximal part distance. Depending on the balloon size, we need to evaluate it. And then we can add a smaller stent later on. What are your opinions about the stent length? Well, this inferior lesion would be better seen. Full coverage is more logical for me. Actually, the incompliance of the stent at the proximal and distal parts are important. In IOS measurements, it would be better. What do you think, Shukru? Actually, 75 and 3, 275 and 3 almost have a similar coverage area. I would leave its part. I would only use a stent for the problematic area, and the inferior part will be controlled on medication because the creatinine levels of the patient are high. Yes. Ömer and Kürşat. We will see how they will continue. The balloon is 2.51. We placed it and we inflated it. When we look at the vein, we can see that it seems to be 2.75. The distal vein bed seems to be like that. The balloon is 18.1. The stent of 38 will be good because for 408 part we have a balloon. Therefore, we start with 2.75, 38 stent, but the expansion capacity is around 10x stent. The visibility and flexibility of the stent is good, and the stent intervals are good. And the expansion capacity is that when it is inflated with high atmosphere, it's around 3. Therefore, we need to select a 3 stent. About this, we have 34. But 34 will be smaller for us. 38 will be better. I would take 275, 38, 1. The balloon length is 18, yes. Now at the part from the diagonal to the upper part, you need some place to go upward. We have other balloons, 408, 308. We can also use them. And after inflating and deflating the balloon, the distal area seems to be better. Did you do nitrate? Yes, these are the nitrated images. Yes, there is some plaque, but in IVUS, we couldn't see whether it causes a serious stenosis or not. If there is a healthy segment after the diagonal, after the lesion, whether to leave the stents at the distal part or not. So do we need to cover all the areas with plaque? There is such a handicap when we take it, when we take these images and when we put the stent here. And that part seems to be odd. And the stenosis is at the distal part of the stent. Therefore, in the following periods, stenosis is close to the distal. And if we put the stent where the plaque starts, it becomes critical. Therefore, when we put it there, we leave the stent there. Therefore, we can be in the secure area. Kürşat, my name is Ergin. I think a short stent would be good. The lower part is not seeming to be critical for me, and the diameter is different. We would try to define the stent also due to the age of the patient, and for a short operation, I would use a short stent in provisional direction. And provisional stent doesn't mean using a single stent. So if there occurs any problem at the diagonal orifice, we can also use a diverse crutch to continue the surgery. Any other opinions? As also seen in IVUS, everywhere has plaque. Covering the inferior plaque would be of no advantage. For me, a shorter stent is better. Even if we use a longer stent, it would be different. There will be not any other contribution. Yes, the comments are right. Actually, the plaque extends to the inferior part. When we look at IVUS, the plaque burden is around 40%, and we can place the stent there. But if the burden is more than 40% or 50%, then you do not need a stent there. But in the IVUS regions, I think IVUS images, the place is suitable for stent placement. Most of the time, we know that the distal part extends to the inferior side. If additional stent is required, we can use it. As generally told, we will try not to involve the plaque here. The balloon is 18. We have 20 and 26 stents. 22 seems to be compliant. 26 would be large. We took 3.0 to enter the stent, and without intervening in the distal part, we will implant the stent and then we will make an evaluation. So if any overlapping is required, another stent would be used. Now I'm sending the stent. You can see the coronary passage. There is an extra backup catheter. Without any friction, the stent is going on. Here, this part seems to be suitable. The septal part seems to be suitable. Plunge the cranial part. $15 millimeters would be good, Kürşat, from septum. Yes, there's no use for that. This will be long. It will be in the plaque. Nominal flow. Increase to 12, okay. Do it 14. Wait. I can take it back. You see, there is no adhesion in the balloon. To see any complications, we can do it. The side branch seems to be good. I will also evaluate the distal now. Sinan is assisting the surgery. If you have such a professional with you, it comforts the operator. Yes, friends, what do you see? The distal size is good. And at the proximal segment, at the distal segment, the stenosis seems to be good. Let's do the parts. What to use with part? 4.0 or 3.5? What do you say, the panel? 3.5 would be good. And what about the result for the distal part? When we do sizing, 2 millimeters must be kept in mind because the stent balloons are out of the stent, but the balloon markers are inside. Tanner, the result seems to be good. The diagonal orifice is protected. I would use 4.0. I mean, in 14 bars, I would increase to 3.5. I think 4 would be good. It was around 4 in IVAS. Any other opinions?
There is a critical part. We have to check this part. There could be, can we see iris right now? We have to see with iris because actually let's have the part and let's oppose the stent and then we will see it iris. We will check it again. What do you do with the 3.5? As Sinan pointed out, we are in 14. There is a 2.3. 4, we will inflate the 4 to be inside the snake. And proximal segment is a 40. It is in I was 4.5. I don't want to be undersized in the case. That is why we have 40 and we have a hot balloon. As you can see, this is what I give it importance to. So can we make it larger? Just focus on the stand. Here when we have the first part, the part distance should be within the sub branch so that we have the strut gap. The sub branch or the side branch movement cannot be seen. As you can see here in Scopy, the wire transition is guiding to me. So we will confirm it opaque. Full, as you can see. I'm in the distal, I will take it back a bit. I will take it back a bit. As you can see it actually. 12. We can open it. 6.8, 10, 12. We can take it back. 2, we can take it to distal. We will align it. I'll go to higher atmosphere. The visibility of the stand, I think is very good. As you can see, our location is very good. I take it a bit more. 12, 14, 16. Kürşat, Professor Kürşat and Ömer, in the laboratory we cannot find and say you say semi-compliant balloon. Do you prefer this? It is very elongated here in your practice. You use semi-compliant balloon or do you take it to higher volume in your practice? Did you hear the question? We were talking among us. I couldn't understand the question very well. In post-dilatation, do you use semi-compliant balloons in your daily practice? If you have it, we use non-compliant balloons in the laboratory. Sometimes you cannot find this, and we don't want to say undersized. When we see semi-compliant balloon, we have to have concerns about the semi-compliant part, and the expansion could be in a certain limit, and semi-compliance increase 401 in the balloon. In post-dilatation, so we can prefer 3.5 because when you are 16, it is a 3.8. In terms of oversizing, I have concerns. But sometimes, as you can say, from time to time we use, this is the final image. It looks very well. We will see IVUS with compliant balloon. I'd like to say something. Sometimes there is no NC balloon, that there could be potting with semi-compliant, but with the semi-compliant in the higher pressures, they float more, like not like NC. So while we're kids, you have to be very careful. When there's a side branch, it's used with the semi-compliant in the proxial. The proxial part should be taken into account, and the distal part and the side branch can be floated more. They will increase the dissection risk. So we have to. Can you see IVUS? There is a ring down. Can you push the ring down? Ring down. Can you push it? They already did. They have to go out of the recording. They have to make a ring down. Make the ring down. Can I make a contribution? Kürşat Bey pointed out a very good point about what that if we take this marker as the basis, we have to go along Karina because we can see the balloon can be thinner and in this thread opening, if we can the marker there, there's the osseous strata may not be open. So you can push, and this is a very good part. This is a diagonal distinction. You can see the diagonal distinction. Diagonal part seems very good. Opposition is very good. I mean the proximal segment. Opposition is very good. 4.0 balloon is this. I take it out. This is more proximal where we have higher atmosphere. This is the proximal segment of the disc. I think that IRIS imaging is very good. Position is very good, and the distal and the proximal segment. I don't need for post-dilatation. If you would like to say, we can take it into consideration. Can we see it in the larger screen? In the side branch, the part after the side branch should be 3.5. Can you go down to the beginning of it? Should down. Let's see. We can see it. You can play it. The lesion, according to IRIS criteria, seems critical, but the angio image is very good. The lesion can be left and distal. Before the stent starts, we have to check to 6 HT dissection. We don't see it. We have to be careful about this. Let's continue a bit. Let's go a bit higher. This region, when you measure it, we cannot achieve 3.5 post-rotation, very good. Opening the stent in 3.5, according to this IRIS, that will be very good. We have to measure it from down. Let's measure it within the stent. It seems a bit critical there. Let's measure it in the distance. Let's measure the lumen from there. Ömer, I think it's very good. We can iterate the side branch. It is 3.5, but the stent is at 3. Lumen is a bit larger, actually. You know, it's up to you. The angiographic imaging is very good. Let's look at this. Can we see the left cranial? Let's look at this. Do you close H dissections with stent, or do you limit if it is not limiting to this? There's OCT criteria up to 4 units, and it should be, if it is more than 4 millimeters, so we have to send it. If no OCT is there in your daily practice, if we see IRIS and we see the H dissection, and there is no angio, we don't touch it if we don't see it in angio, because it could be very ambiguous, and if there's edge dissection, if it is a small, we leave it, and if it is large, we send it. I think this is very satisfactory. I'm not in favor of post-dilatation. As you can see, the sizing is very good in the area where we left the stent. And the edge dissection in proximal and the distal segment, it is not present. I think that the panel's contribution is positive, and I said in the beginning, I thought I could go there 38 centimeters down, but this is the last image. I'd like to attract your attention in the diagonal level. We see that narrowness, and we can say when you take it from the late cranial part, you can see that if you want to see the lesion of the diagonal, you have to look at the advanced left diagonal position. From the right hand side, you see that there is no problem in the diagonal mount, and we can say that you have to look at the lesion from different angles, and this is very critical. In this position, ostium and OLED is overlapping to an extent. So there's extreme right cranial. If you do extreme right cranial, if we can see it from that part, very good. This is the wired. I pushed the LED wire, and as you can see, it's been a bit challenging, but it wasn't a problem for us. Let's take it to final positions. The nitrate, let's see it. What is the blood pressure? Blood pressure is okay. Left cranial pulse. The bridge is the same. If you want to take the plaque, the part of stent will be within the bridge. So what is your approach in such a case? It shouldn't be there, because if it is there, there's a risk of dissection. And once you have I presented the case, after opening, you can have nitrate. When we say bridge, it is intramolar part, and sometimes partially intermolar. When it is partially intermolar, so it causes some compression, and so total intramolar course, there are problems, but it increases the rupture risk. When you oversize the size, it causes dissection, and it causes a complication. So for the distal, not going too much at distal, it's about avoiding the complication. So we have to check it with this instruction, diagonal bifurcation in the lesion distal, if there's muscular bridge, or if there is epicardial intermolar course, we have to check it. We check it with IVUS, so it doesn't show an intermolar course. So I'm not sure whether there's intermolar course or not, but there are some risks, and this makes us very careful about the case. I'm taking the final images. If you wish, we can finish the system. Let's see it from the other part. Can we take it from this catheter? I think that is enough. These are the nitrate poses. This is the last images at the sub branch. The side branch is very good. In ostial segment, there is the narrowness, but hemodynamically it doesn't cause any problem. okay, Sinan, if you want, so there's the tributary flow is there. We don't have H dissection. This is a dissolution. I think that this is satisfactory for me as well. We don't have a complication like a rupture. There's no dysembolization. There's a tributary flow. If that is okay for you, I'd like to finalize this case if that is okay. Any comment from the panel? Thank you very much. That is very good. Hemodynamically, there's a shift, but it is not so. For the discussion in the young cases, so is it better to have double stents or it's better to have provisional in young cases? I'd like to discuss that. Should I answer the question? Yes. When you have the double stent strategy, the side branch opening is better. With provisional strategy and the double stent strategy, clinically there is another anatomically. We can say this. It is not right to speculate about this. So we are physicians and we're here for eliminating the symptoms in the patient. That the patient has a chronic renal failure. And of course, the clinical studies results are not very clear. This is our main strategy, but we can have this after report regarding the gap of the side branch, and if there's a dissection in there, if there's if we think that we have to open there, we can have kissing balloon in this patient, but there is a problem with that. We know that there's a lesion in that part of the patient, and so if we cause a dissection, so we have to have 2.5 non-coupling balloon, and there can be a dissection. From bailout strategies, we can have the reverse crunch, or we can have flap. In this patient, I don't want to have the second stent. So the excellence is a thing to good. So I don't think that I'm not in favor of getting into more in this patient. This is very good. So there's a balloon gel structure is there. So in this patient, you can say that the gelling is better in this patient. So in IVUS, we can see that. So in the first IVUS, in diagonal, but before you start the procedure, so do you think that we can put it there in the provisional techniques, in the defined provisional techniques? So regarding the wire, we have taken the security measures regarding the wire. But if we have it balloon, there's a speculation to say that our results of it will be better. So we have to make comparison. Balloon gel is one of the alternative, and NİHAT said that balloon gel, but we talk with Sinan, so we can have more practical, and we have the standard and provisional technique that we applied. So that the result could be good. It might not have been. I cannot say anything about this. But the side branch result is quite satisfactory right now. If there was a dissection, if there's a flow of decrease, and if there's a blood shift, we can think about it. But this side branch is a very satisfactory. About the gel balloon, I'd like to say this. To what extent there's blood shift? Can we have kissing? I don't think that we can have kissing in this patient. I accept this result. If that was a young and active patient, So I could have wanted to have kissing. Let's talk about the jail balloon. Why do I have jail balloon? In such a patient, what is the benefit of kissing balloon in this patient? After putting the stent, it's very low that we will lose this center. Line wire is easy. Wiring the patient is not very difficult. Gel balloon, I use gel balloon. And if there's a side branch and it is not as big as putting a stent, rewiring is difficult. So 1.5 or 2 mm of balloon can be parked there. You don't think of a stunt. You don't want to lose it. You can have gel balloon. You can have the stent. You can have kissing so that you can open ostium of the side branch. You can have kissing and in terms of gel balloon, but in such a patient, so it I don't understand the jailing of the patient. Gel balloon is a very simple procedure. The diagonal and side branch is wired, and you park the balloon, and we just take it out. It is not challenging, or it doesn't bring about any problem to the procedure. In the advanced left cranial, there is the shortness. However, before that, in the ostium, in the left cranial, there isn't much angle, so there is a kind of shift. So in such a shift, with a very simple procedure, you can select solve with the parking of a balloon. If you have to inflate the balloon 3 or 4 atmosphere, it is not only about parking the balloon. In such a cases, so I could use a refire. You inflate the balloon and you make pots then. It selects the corner shift, but there could be fail, but there are many cases that it works. So we want to take out the patient to prepare for the next case. Thank you very much for your comments. I'd like to thank the laboratory team. I'd like to thank Sinan as well. This has been very nice as a case. First and foremost, so let's listen to NİHAT Bey. ABACI with the case presentation. Can you make it full screen? I'm very happy to make a presentation here. And I'd like to thank the organizers. We have a case, a 30 years old patient, and he's an assistant in our university. For 10 days, there's a typical chest pain. In 5 meters, he has to rest for 3 times. In ECG, it is normal, and the physical examinations is normal. But the patient came to us at the end of the day, as he's in 30 years of age. We were thinking we wanted to have an info test. And in the first moment, in the first minute, there was a chest pain, and echo, there wasn't any change, and it was within the normal limits. So as the patient has a typical, we planned a coronary angiography in the patient because the pain is typical in this patient. In the coronary angiography, as you can see, with the different poses, we have the images and ostium of the patient. There's a critical lesion, as you can see. There isn't any problem at other parts. In other parts, we made a nitrate. So one uses this is 8 micrograms and nitroglycerin is made in intracoronary in this patient, but there is no change in there. This is a cranial image. As you can see ostium, and there's a critical neuronus in this patient, as you can see. After the repeating nitrate doses, you can see it. We made it larger, we made the image larger, and we took an imaging. As the patient has the symptoms, as we think the lesion is critical, we we made a planning for this patient. You can see from the right-hand side. So in order to understand what is what is the underlying, in order to have the procedure, first we planned an IVUS in this patient. This is the IVUS. This is the allogenic part. I'll be fast here. Sublate limit part, you can see there are plaques. As you can see, there is the LAD ostial part, and here in this part, we think there's a soft plaque. We have a lesion here. This is the CX part, and we can say that there's 4.7. This is the main coronary. And the main coronary, there is no visible lesion. This patient is a young patient, but in this patient, so there is calcium plaques, and in the plaques, so we evaluated this as a soft plaque in this patient. So here, we write 6. As we think it is soft, we discuss a stent implantation, and there's a 22 millimeters corpus stent is to be implemented here, as we decided. It was a difficult for positioning. We had to take back the wire. So here, this is the stent. This is after the stent implantation in the omega part in the main coronary 508 balloon used for the potting procedure. We have one other iris imaging after that. As you can see, this is the part where the stent starts. As you can see, LAD ostial part, our stent is partially, it is not opposed very well.
As you see here. And then we put 4.5 10 millimeter balloon in the LAD ostial area. We dilated here with a balloon, and at the stent area, we repeated our pot. And we completed our surgery. These are the angiography images. And here is the LAD image. Here, especially, the patient is young and the underlying reasons were to be searched. Therefore, this imaging was done because a spontaneous coronary dissection might occur in the patient. Therefore, IVUS was required because the treatment strategy would change. Therefore, with this IVUS, with the stent implantation, we completed the operation. Well done, okay. After the first stent implantation in angiographic images, was LAD proximal good? Because in IVUS, the stent was not opposed well and the stent didn't open. Did you see it in angiography? In angiography, it was very good. There was no problem. But in IVUS, the malpositions were seen clearly. It's very important, especially in these young patients in ostial LAD and main coronary artery. Verifying the results with IVUS is valuable. Therefore, I'd like to congratulate you. Ömer, would you like to add something? The case was really good indeed. And there might be a spasm or whether it was correct, and IVUS verification was also good. With a single stent, you did it, and it was very good indeed. Okay, well done. We discussed the case previously. IVUS is really important here. It could be interpreted as a spasm as the patient was young. But thrombosis, hematoma, separations are also important. Here, if there is any intraoperal hematoma, the lumen could be differentiated. Thrombus is most of the time in the intralumen, but there is a calcification. The plaque is solved, but there are hybrids. Then we decided that it was a lesion. And before the last part, we saw it. And therefore, it was a very good case. Thank you. Thank you again. I would give the floor to NİHAT KALAY, the last speaker of the session. Optimal PCI will be the topic of his speech. Thank you very much once again for your participation. Optimal PCI, actually for 7 years, we have been holding these invasive meetings, and how do we do the PCI? How can we optimize? This is our target in these meetings. We are trying to see it. Invasive operations, of course, contribute to mortality, but if we do it in an optimal manner, our contribution gets higher. Therefore, we need to work better to optimize our work. When we say optimal PCI, there are many factors. The appropriate patient must be given the appropriate operation under ideal conditions. The anatomic structure of the patient is important. The materials, comorbidity, all must be taken into consideration. Appropriate product must be selected. And after the operations, there are 2 situations that we are afraid: stent thrombosis and stent stenosis. The actual process, important process, is after implanting the stent. When we see all these, unfortunately, the invasive operation efficacy decreases. But if we optimize the operations, the stent thrombosis or stent stenosis is reduced, especially stent thrombosis is getting lower. And with Ali Hoca, we already discussed it. And it depends on the optimization of the works. If we do the stent if we do the operation optimally, stenosis also decreases. So what do we need for an optimal PCI? Angiography, IVUS, FFR. Let me talk about a few studies, especially the studies show it actually. In angiography, we have the chance for an optimal PCI. Very little ultimate study shows this actually. If we do this for a patient with imaging, the results are better. If a suboptimal PCI is done for a patient, restenosis possibility is around 4%, but in optimal PCI, it is decreased to 1%, and the complications disappear with these patients, and the late period restenosis also decreases in optimal PCI group, unlike the suboptimal PCI group. And FFR is very important. We cannot use it frequently, but of course it's an indispensable part of this work in the morning case. We could also use it. If we do our work with FFR, we get the results very close to surgery. You can see that, and this is the NECMI letter issued this year. Actually, if in this patient group, if we do the works with FFR and decide about the stent with these, the non-inferior PCI and surgery are equal. So what is our criteria for an optimal PCI? The dissection is not wanted. An optimal an optimal surgery is required. What's our IVUS criteria? Here for the main coronary, if the area is over 5.5 square millimeters, then the patient is ideal for an optimal PCI. And the lumen plaque load must be bigger than more than 50% at the distal. Then the complication ratios decrease. FFR is very important. It is actually recommended for an optimal PCI because a majority of the patients give 0.80 ratio, and you can see the stent extension here, and we can do the repotting, and the edge dissections and monopositions are important here, and we can evaluate the stent diameter in this manner. And we already said that angio is not adequate. Generally, we see underexpansion in these patients only with angiography. It's around 80%. And the geographical recurrence, most of the time, the lesion is within the plaque, and this increases the risk of retinosis. And in 23% of the patients, edge dissection is seen. Apart from that, malopposition is a serious problem. Unfortunately, with angiography, we cannot understand it, and it increases the miss rates, especially edge dissection increases the risk. And underexpansion is also an important issue. It's one of the most important suboptimal operations. It's most of the time related to calcium. And sometimes we cannot break the calcification. Is angiography enough? Unfortunately not. And nearly 50% of the patients are ignored calcification. And IVUS is the most appropriate technique for seeing the calcification. In 99% of the patients, we see the calcification with IVUS. The technique may change despite the facilities, and if the calcification is thicker than 0.5 millimeters, then high OPN prolonger may be used to break the calcification. This is an optimal PCI flight after the operations. Even if angiography seems to be adequate, we want a QFR value less than 0.89. If the value is less, there may be a few reasons behind this. There might be dissection or geographic need. If we see all these, every operation may be required. And after the operation, if 37% of the patients show an FFR value of under 0.82, only in 32% of the patients we see an FFR exceeding 90. Therefore, if possible, we may require an FFI evaluation. IVUS is very important. We are always emphasizing it. You can see a lesion here. A partial calcification is seen in angiography. I will show you the severity of this. This is a circular calcification. It's quite thick. In this region, these are totally calcific. And actually, when we see it, our approach may change. We use a rotablator or we use high pressures. We increase the pressure for this patient. Here I will show for expanding the stent, you need to break the calcification. I will show you some of the breaks. These are the broken areas. Without breaking these parts, we cannot open the stent. As we see these breaks, we did the stent implantation and ensured an adequate clearance. Thank you very much for your patience. Thank you very much for the presentation. We are now coming towards the end of the session. I would like to thank all the panelists and the members here very much. Thank you very much. See you at the next